broadcast is now starting. All attendees are in listen-only mode.
Hey Dan, is the mic on? Okay. Let these people sign in. Okay. I'm Karen Mcgovern. I'm the Deputy Director for the Division of Professions and Occupations, and I work with the programs and the legal affairs for the division. First, I wanted to thank you all for attending this stakeholder meeting. We have a number of people here in person, and so far we have 56 people who are attending via the webinar. This is the first of two stakeholder meetings hosted by the division. To discuss the draft revisions to the policy for prescribing and dispensing opioids. As many of you are aware, the division has hosted a total of 5 stakeholder meetings prior to today. We went across the state. We held a town hall in Pueblo, one in Greeley, because prior to undertaking any revision, we wanted to hear from the community regarding what they wanted to see in our policy. The Colorado licensing healthcare boards, are seeking the input of the public on this draft revision because we need to understand the impact that this policy will have on consumers and practitioners. We're interested in any positive impacts that you see or negative impacts because it's important to gather that information before we finalize any policy. I think your opinions and recommendations are critical to help us shape the final policy. We held all of those stakeholder meetings before we started, but in my experience, I find that some of the most important feedback comes when people can actually see what the proposal is and then offer their feedback regarding that. With that, I'd like to introduce you to Kyle Brown. He's the Senior Health Policy Advisor with the Governor's Office of Policy and Research. He will discuss the importance of this opioid policy as part of the broader executive efforts to address the state's commitment to combating the abuse and misuse of opioids. Kyle?
Well, thank you, Karen, and thank you all for being here. I really appreciate it and appreciate you having me here today. As part of the governor's kind of a broader healthcare agenda, he's really prioritized the opioid epidemic in general as part of this, as a very significant and serious public health crisis. And really since the beginning of his administration, from helping to start the Prescription Drug Abuse Prevention Consortium to some of the more recent efforts that we've been fortunate to be involved with, as led by DORA, CDPHE, HCPF. So, I think in order for us to comprehensively address the problem, the governor has really called for sustained coordination and collaboration among the healthcare communities, educators, state, local law enforcement, public health, and human services, community groups, and our legislative partners. And it's that kind of collaborative spirit that the consortium was based on, that the Quad policy is based on, and that this meeting ultimately is based on. That is central to helping us to address the opioid crisis. The Lieutenant Governor has also been deeply involved in all of this and has visited it within the first year of her tenure as Lieutenant Governor, visited all of our 64 counties, and the things that she heard the most was about broadband and healthcare, and specifically the opioid crisis. Employers not being able to find people to fill the jobs that they have because they can't pass a drug test. People dying because they've become addicted. So, we're committed to continuing to address this. We've made good strides over the last several years, but we're a long way from solving this. And this policy and the revisions to it are a key part of making sure that our agenda continues to move the needle, reduce deaths, reduce addiction in Colorado to opioids. So I'm looking forward to hearing from all of you and all of your perspective on the revisions that have been proposed, to hear what's important to you all. This is part of one step in a very long and collaborative process. Obviously, that's the way that we do these things here in Colorado, and it's the right way to do things. So with that, I'll turn it back over to Karen. But I just want to thank you all for participating in this, and thanks for helping us make Colorado the healthiest state in the nation.
Thank you, Kyle. So I want to talk a little bit about how we're going to structure things today, because I think we're going to switch up a little bit from the last stakeholder meeting we had because I want to make sure that we hear from everyone. Before we start, I wanted to talk a little bit about the draft policy and just make sure that, we get the ground, kind of the baseline for what we're intending to do. First of all, I always like to remind people that this is a policy. It's not a rule and it's not law. It's guidelines to help prescribers, and particularly those prescribers that may not have a specialty in pain management, so that they can adequately address the pain of their patients. There was a study that was done by the National Institute of Health that talks about that 11.2% of American adults report having pain on a daily basis. So this policy, while it's intended to help combat the abuse and misuse of opioids, is equally important for people to understand that it represents guidelines to compassionately treat pain. There's nothing in the policy that says don't treat a patient's pain. It's make sure that when you're treating the pain that you're looking at all the options and that you're assessing the risk to the patient, that making sure that the opioids are providing a greater benefit to the patient than they are a risk before moving forward. I think we have dropped some of the bright lines, and that's what we call them, bright lines. So if you're talking about 50 morphine equivalents being a bright line is when we're asking prescribers to stop and think. You're at 50. Stop, think, rebalance the risks and benefits to the patients before you move forward. Think about what risk mitigation you can put in place to ensure that patient is safe and that they don't become one of the thousands of people who die every month in Colorado from overdose, right? What can you do to make sure that their pain is addressed while making sure that you're keeping them safe? We made sure that the policy was clear to say that this policy is directed toward adults, 18 and older. There are specific, and it was pointed out at one of these meetings, it was so helpful, is that treating children is so much different than treating adults. And so we want to make sure that if you're treating children, you need to consult with a pediatric specialist. We don't want you to look at these guidelines and say 50 is good for a 4-year-old. And then I think that we hoped in this policy to inspire people to be creative in treating pain. When someone comes to your office and says, I have back pain, think about all the ways you can treat that back pain instead of just writing a prescription for opioids. Writing opioids should not be the first option that you consider. There should be a consideration of all the alternatives of creatively treating that pain, because a very important step to combating this abuse is to ensure that you never get people started. With that, I'm opening it up for comments. We have roaming microphones, so if you'd like to make a comment, I'd like you to raise your hand. We have a microphone on this side of the room, and then we have one over on this side, and we will get to everyone. And then for the webinar, the webinar, we will interject and make sure that we're including them in the conversation when they need to make comments. So who wants to be first? So we could start with, maybe I'll throw some things out to you. Who here has concerns about dropping the bright line to 50 morphine milligram equivalents a day? And would you like to make a comment on that? Okay. And Abby will bring you the microphone.
Good afternoon. Can you hear me? Hold it up for your mouth. Can you hold it up? Hello? It's technology. Shall I just start?
No one should just shout. We want the webinar people to be able to hear, so maybe Amy can bring hers over. No.
on the bottom, Paula.
Yes.
Yeah, power's on, audio's on.
There we go.
It's on now.
There's on.
Okay.
Yes, perfect.
Okay. Good afternoon. I'm a licensed clinical psychologist, and I've been practicing in Colorado since 1986. I've taught at the University of Colorado in Boulder and at the Boulder Institute for Psychotherapy and Research. I have treated and treat both hospitalized patients and outpatients. One of my primary areas of expertise is trauma. And today I'm speaking on behalf of myself and my colleague, Dr. Louise Silvern, who is a retired professor of psychology at the University of Colorado at Boulder and is the author of numerous research articles on trauma and perhaps most importantly for this context, on the effectiveness on community-based interventions, of which this is proposed to be one. After looking at the policy, we wanted to make several suggestions. First, we think it's really important to add a qualification to the policy statement about the nature of the empirical support that underpins the recommendations. And here, we're talking today as both as people who are experts in both research and who also have clinical practices. When we put our research hats on, it is very clear that the empirical support for the policies at this point is very tentative. And we can provide references and citations to anybody who would like. In fact, there are very important ethical reasons to qualify the policy given the tentative nature of the research. Specifically, we have heard from many psychotherapy patients who are in pain and, on a more personal level, from our friends and our colleagues that they are terrified of what's going to happen when there are dosage restrictions and prescription restrictions. What this policy is doing is creating fear and mistrust in the patient population so that patients are no longer trusting their doctors. We are putting patients in the untenable situation of thinking they were being mistreated before when they got the supposedly too high doses, or that they're being deceived now when they're being told this is for their own good. As a result, people may be turning to other ways of mitigating their pain. To deal with this relational issue, this trust issue, which is essential. I mean, we know that medication compliance increases as a function of trust in the patient-doctor relationship. Given that, we also have to think then about compliance issues. So to be completely candid, we would imagine would be the best option here. And what we're talking about is to add basically the truth, which is that at this point, the research is incomplete, that the policy is an attempt to address the overdose problem. But right now, the research itself is far, far from conclusive on whether overdoses, the increase in overdoses, are actually caused by prescriptions or by increases in prescriptions, since there hasn't been an increase in prescriptions. There's been a decrease in prescriptions. And this is just data. I'm just sort of, and again, we can provide the citations. we want to urge these specific changes so that actually the goals can be met, and the goals being, of course, to reduce deaths and to care for patients who are in pain. And that means taking an empirical approach to see what actually works. One of the more specific suggestions would be to question the idea of decreasing the MME. I mean, just a few months ago, the magic number was 300, and now it's gone down. We know that research and science doesn't work that quickly. The other piece is to be very careful, again, about the actual studies and the research we're basing life and death decisions on. For example, one clear problem with the studies is that they don't measure pain. They treat all patients who are on pain medication as if they had the same level of pain caused by the same level of medical condition. As a result, they're prescribing a one-size-fits-all solution. We know that doesn't work in healthcare. What we're urging very strongly is that there be a policy built into the overall policy for effectiveness-based research, and that the policy be responsive to the data that we gather. Thank you.
Coming down today and for sharing your feedback. We had someone else on this side that had their hand up to speak about the dosing. Don't be shy. Anybody? Here we are.
Test. It's working. Hello. Okay. My name is Dr. Susan Guthrie, and I'm a licensed marriage and family therapist in Boulder in private practice for 24 years. I have a doctorate in health and human services, and that doesn't mean that much in this situation, but I do understand the research, and I was, as a therapist and people who are in chronic pain as my patients, I endorse what you just said. First of all, I'm glad that opioids are a controlled substance and that there's monitoring of that. And because it's important, nobody wants to get addicted. And okay, so, but it does feel like a bit of a witch hunt to me. President Trump yesterday came out with a strong statement about the abuse of opioids. And what strikes me as kind of odd here is that about 300,000 Americans die annually from being obese or overweight. And of the 570,000 Americans who die from drugs annually, 570,000, 480 of those are from cigarettes. And of those, 29,000 or 30,000 died from opiate overdose or addiction. Not a small number, but it's a fraction of the risk, or it's a fraction of the deaths compared to obesity and cigarettes and alcohol. Although I don't have statistics specific. Okay. We live in a society that's pretty addicted, and we abuse substances. A popular statistic is that 80% of heroin users started with prescription medications. And I'm quoting from Scientific American, so whatever you think about that as a source. But 75% of all opioid misuse starts with people using medication that wasn't prescribed for them. And again, I'm advocating for people who are on medications legitimately. And 90% of all addictions, no matter what the drug, 90% start in adolescence and young adult years. And if I'm talking to a room full of people who used alcohol in high school, that's when the abuse starts. And anyway, I don't think it's prescription drug use that we're talking about. But I want to share a personal story. There's more and more piece of research from University of Michigan that it's this type of drug use, so drinking in high school and early use, not medical treatment with opioids, is by far the greater risk factor for opioid addiction. Your good intentions and Colorado's good intentions have created and will continue to create some bad repercussions for people who legitimately use opioids. And it is very threatening to those of us who use opioids. And we feel like criminals, a lot of us. And every time we look at our pharmacists, we know kind of that they're assessing us. So I always try to look put together when I get my prescription. No, I don't really do that. And it seems to me like we're bypassing the common sense, wisdom, and discernment of physicians. Now, my complaint here is that I have a chronic lung disease called bronchiectasis, and it's an unusual disease, and it involves not difficulty breathing, but the sensation of breathlessness and pleural pain and also burning in my lungs. And it's uncomfortable every day of my life. At first, I just kind of stayed at home with it. I'd stopped socializing. This was like 10 or 15 years ago. This causes a widening and scarring of the bronchial tubes. I tried every over-the-counter cure that there was. I tried inhalers. My doctor tried a lot of different things. None of them created any kind of relief for the pain and discomfort. And eventually he prescribed opioids. And I am prescribed, I don't know what this means in terms of morphine, but 7.5 level of Percocet and a day. And I don't usually take that much. I don't need that. 2 years ago, I had a bad skiing accident, and I was in Beaver Creek, and I got some pain medication from the ER doc there. And he said, when you come back to Boulder, go see an orthopedic doctor and get an x-ray. And I did, and he prescribed, I had a sprained ligament, which was really painful, and he prescribed opioids. I was not at the time, so I got that prescription filled, and I got it filled not at my normal pharmacy, but I was in Louisville, and I went to the Louisville pharmacy. Well, that pharmacist, because I'd gotten a prescription in Beaver Creek and Louisville, flagged me, and 2 different prescribers, so really 3 different prescribers, my pulmonologist and then the guy in Beaver Creek and the orthopedic guy in Boulder. They flagged me, and they flagged my physician. And so I'm on the list, and my understanding from my pulmonologist is that I can't get off the list, and he's on the list. And I don't know much about the list, so I have to say I'm projecting here what it means to be on the list. But so I went into his office, he called me into his office, and he came after me and said, what are you doing? What drugs are you on? Who is Dr. X? Who is Dr. Y? And it was not a skillful, he's a pulmonologist, he's not a psychologist or an intervention specialist, but I could tell that he was scared. And I don't know what kind of threat to his license, but I'm guessing that there is a threat to his license. And that does not seem legitimate. And it's not legitimate for physicians, and I've read blogs about this and talked to other people. It's not legitimate for physicians to break the rapport and bond and trust and do some kind of drug intervention when they have no data to support that other than a pharmacist who, got suspicious because things didn't line up for him. There was no interview of me. There was no discussion about how it happened. I did talk to my pulmonologist about it. He said, "Oh yeah, I remember you had that ski injury and blah blah blah." And so, but it was really an awful experience. And as a therapist, I thought, if I'm a privileged person having this experience, and I work with homeless people, what's happening with those folks who don't have the resources or necessarily the resources or the ability to kind of move through the system and understand what happened? And so it seems to me like and I don't know this for true, but I really think that our young people are depressed, and there are a lot of other complicating factors. And I don't think that just calling this an epidemic and diving into it, I think it's kind of like prohibition. And I'm not saying that this stuff isn't useful and this education isn't useful. So that's what I think. And then the other thing is, I wish I would have been warned by my physician. And I kind of read into the new guidelines. Someone should have told me, by the way, you have to shop at the same pharmacy and you can't have more than one pain provider. Because I was just kind of going on the circumstances. Anyway, I think that's all I've got. Thank you.
Thank you so much. Really appreciate you coming down today and sharing your story. Okay, who else?
We have one.
Okay,
And can you have people in the room identify themselves, please?
sure.
People are sort of lost on the bowl.
Yes. Can you hear me?
Oh, yes, yes. We can.
Okay, so already the theme is exactly what I have to say. I do have multiple chronic diseases. I am a licensed marriage and family therapist in private practice, but I have worked in agencies here, Mahasa, and I've seen this over and over again. There is the fear factor of, you have to play the game exactly right. I'm a very smart person. I'm educated. I know what I'm doing, but there's plenty of people who do not. I now have a pain management specialist, and he just the other day said to me, they don't want me to exist. They wish I weren't here. And what the woman before me just said is critically important. I had to sign a 25-page contract that said you will not get opioids from anywhere else. You will not use marijuana. You will not do this. You will not do that. I am urine tested every, random times, all kinds of things like that. But to get to that point took me years of building up trust to get to that point. And I must have 8 problems. I'm not going to go through what they are. Those obscure diseases that cause excruciating pain, loss of sleep, all kinds of things like that. So there's that concern about both women saying it needs to be not just a one size fits all, and also exactly what the second woman said, which is, patients need to be told by physicians, if I'm going to prescribe you opioids, you're not to get them anywhere else. Sign this document or whatever, so that kind of crazy snafu thing doesn't happen where you're flagged for doing essentially nothing wrong. Now, I already knew that, and as soon as she said she went somewhere else, I'm like, uh-oh, she's in trouble. right then. But the other point is we're looking at this from the wrong end, and we always do in this country. We don't win the drug war. Every so often it's opioids, then the next time it's something else, the next time it's something else. It just goes in a wave. Where are the drug treatment centers for people without money? There aren't any. Most of them are for people with money. If you don't have money, this was a problem when I was in agency work. There's nowhere to send these people. There's every single person that came into my office, I would say 90% of them had one thing or the other: alcohol or drug abuse, not addiction necessarily, but abuse issues. I had nowhere to send them. Not even the Mahasa, the 5 big agencies that are in the Denver metro area. Only one of them was designated to handle this, and they had a tiny little alcohol and drug unit that could only take so many people. Half these people don't even have their own transportation. It's ludicrous. Now, I don't know whether this policy is designed to say anything about that or not. We need to develop a systematic way of expanding treatment centers. Yes, we have a policy. Yes, we have a crisis. Yes, we're not going to give any money to it. We have an emergency, but no money. It's nuts what we're doing. So really, if we're going to say anything at all of importance, that piece is huge that we need to say something about, because a lot of us are in the treatment end. Where are the treatment centers? If we really care about this stuff, where are they? They're non-existent. Most of them are insurance-based. If you can get a 30-day treatment, you're lucky. 30 days doesn't cut it for this kind of stuff. Just doesn't. That's mainly what I want to say, is that there needs to be something about, telling people this is not to be punishing. This is not to be punitive, because it does turn out to be that way. I've been on opioids for years, and now I don't take very much, but at one time I was on multiple opioids. I was practically an invalid. And the judgment is unbelievable. The look of, you just want to lay around and do nothing. Oh, right. I want to be this way. Nobody wants this. Believe me, it's a horrible life. But the main thing is, where's the other side? Where's the treatment? These people can't get treatment. There isn't any way to do it. So that's something I would like to see added if possible. I don't know whether that's a bent in this thing or not, but I would love to see something about that in here that says, we don't have any treatment centers. We're going from the other end. Don't give people any meds. Well, it's too late. They're going to get them whether we give them to them or not. That's just the way it works in addiction. So that's really all I have to say. I'm very concerned about the people who actually need them not being able to get them. There was some sort of talk about, we're only going to give out 7 or 10 pills at a time. My pain guy is an hour from me. That would be horrific if that happened. So that's really all I have to say. Thank you.
Thank you so much for sharing your perspective. We really appreciate you participating via webinar.
Do you want to do another
Sure.
one? Okay. The next webinar is Catherine Hassel.
Good afternoon. Thank you very much for the opportunity to follow on our that lady's commentary. So I'm an adult hematologist, a full professor at the University of Colorado, where I care for adults living with sickle cell disease, which is a painful disease that contributes not only to ongoing real bone-crushing pain that can become chronic, but also to the development of what we would call a chronic pain syndrome, even if the disease is relatively well controlled, such that about 30 or 40% of adults with this legitimate life-threatening condition are affected by severe chronic pain. At this time, I am often their principal opiate prescriber, because these are often African Americans who are underinsured, who do not have access at the University of Colorado to the one nurse practitioner and the one interventional anesthesiologist in our pain clinic that do not take Medicaid, and do not have access at my university to primary care providers because there is a quota on Medicaid patients. So I find myself in the uncomfortable position, trained in hematology but not chronic pain management, trying to alleviate the suffering, minimize the hospitalizations, and addressing a very real medical condition. I would welcome the opportunity to share this burden and or hand it off to an expert in pain management. And so I'm interested in the plans for the program insofar as this is addressing Medicaid patients. To what extent is there expanded support for physical therapy, alternative medications, access to expensive alternative non-opiate pharmacologic interventions, and to the experts who can actually render this beyond what I can do as a hematologist?
Okay. Thank you, Catherine. you want to go back to the room or do? Okay.
Sure. Okay. We have someone over here.
I'm Shannon Jantz. I'm a family physician, and I'm here representing the CAFP, the Colorado Academy of Family Physicians. And I want to second on a lot of what Dr. Hassel just said. I think one of the things that we really see a significant amount of treating chronic and acute pain is the fact that modalities that we know work, physical therapy, acupuncture, massage, are very expensive and oftentimes not covered, and so patients can't afford them. So it's great to have a policy saying do all these other things, but when the patient can't afford it, that's a real challenge. So I think we really need to figure out, and I don't know what the role of DOOR is, so I initially wasn't going to bring that up, but I think it is something important to think about. The other thing that I think is equally important is the education of the public. As a primary care doc, when you have somebody who comes in your office and they have a low back sprain and they automatically come in saying, I want my Vicodin, it's an uphill battle. And it's very different when somebody walks in saying, what do you think? What are my options? Instead of walking in already with a plan in place. And I think we really need to work on how to educate the public around the fact that these other modalities are out there and they are helpful and they're safer. And so I think those are two things that I think certainly need to be focused on. Just briefly, in terms of the morphine equivalents, those are in line with the CDC guidelines, which the AAFP has adopted for all family physicians. So those are ones that we already have as guidelines, at least for family physicians across the country. So I do agree that flexibility is important, but I think there is some data about hyperanalergia with higher doses, and that higher doses don't actually improve pain substantially. So I think there is some good data that supports kind of at least starting with lower doses and being judicious with higher doses. Thanks.
Thank you so much for coming down and for sharing that information.
My name is Jonathan Ranieri. I'm a licensed pharmacist in this state and in the state of Tennessee, where I practiced the last few years, and I've recently moved to this state. I am representing Centura Health pharmacies that are at a number of our hospitals around the state. And just to comment on the morphine equivalents, I absolutely agree with the idea that everybody's pain should be treated differently, but just based on the medical research and data linked to these hard lines, they shouldn't necessarily be treated as absolutes, but just as a pause to think about the possible risks going forward above these doses. And just like any medication, if I receive a prescription, for a dose that seems unusually high, it's, absolutely my responsibility to call and get an explanation. Perhaps it's a very high thyroid dose. Likely the medical staff, nurse, or doctor would respond, well, this is what we've done so far. The TSH is, through the roof. We've tried these doses. This is why we're here. And so I believe that by looking at these lines, and the pharmacist that holds a corresponding liability as the provider does, we then can get in touch with the patient's provider and obtain a reasonable explanation. And as long as that's there should be no issue going beyond these lines. But at the same time, a lot of times when I call providers, I get zero explanation other than, well, this is where we are. And that's sort of the problem that a lot of pharmacists face. Thank you.
Oh, we have someone over here.
I'm Bob Sammons. Is this on? I'm from Grand Junction, Colorado. I'm a psychiatrist. I have a PhD in clinical psychology. I also helped set the Department of Air Force treatment of opiate addiction coming out of Vietnam in 1971. So I've been in the fight for a while. I am absolutely in the trenches in Grand Junction. I'm the only psychiatrist that has a waiver to use Suboxone to treat opiate addiction. It is a significant problem. I probably get 10 phone calls a day. Let me address a couple of things very quickly and then go to a main point. One of the speakers on the call-in we're talking about the need for treatment. Maybe I'm just cynical after all these years of treatment. We have treatment, but we don't have anything that's effective. The issue isn't getting people into treatment. I'm always startled when I hear that because our treatments don't work. And it's not because people aren't trying, it's because the various drug addictions are so difficult to treat. They were mentioning pain contracts. I have pain contracts. It's amazing how many people will read them and then come back having been to the doctors or gotten medicines in the yard, what have you, saying, well, I just really didn't understand. Part of the reason I have a pain contract is because, about 2 years into prescribing Suboxone, I was visited by the DEA who reviewed my Suboxone charts to see if I was a pill mill. They said I had to have a chart. They said I needed to have zero tolerance of people breaking the contract. If I didn't have a zero tolerance, I was at risk of not only losing my special license for Suboxone, but losing my regular DEA license. So a couple of things. Number one is I get sent chronic pain patients all the time. When they have developed a tolerance, the physicians are no longer willing to go up, and they send them to me. I can absolutely tell you, in a private practice situation, antidepressants do not relieve pain. They may be one modality that can help reduce it, but I've never had a chronic pain patient get off medicines because they're on antidepressant. It's a fallacy. Second, if you take people off pain medicine, you've reduced their opiate dependency, but you have not taken away their pain. I've had 2 patients this year. One committed suicide due to the pain, could not get under control. Even with Suboxone, it was hard to control, and they killed themselves because they had pain. This is what I face when people send folks to me. I have another woman who's overdosed 3 times this year because she cannot get sufficient pain relief. In my use of Suboxone, I started to treat opiate dependency. I now treat chronic pain. For those of you who are not aware of this, I use Suboxone. It's the first medicine out. They've got another medicine out called Zoloft. I've never been visited by drug rep with Suboxone. I want to give my experience very quickly. What we need is what the New England Journal of Medicine stated earlier this year. We need to come up with more addiction-mediated medication. In the medication buprenorphine, which is a basic opiate in Suboxone Zoloft, is that it is a partial agonist, meaning it does not bind to the receptor site like a regular opiate. If you take heroin, if you take fentanyl, morphine, you keep going, and it keeps going higher till you reach a level that knocks off respiration, and that's how people die. Interesting, you don't die from an opiate withdrawal. Feel bad, but you don't die, unlike alcohol. With Suboxone, you get a ceiling effect, or buprenorphine, you get a ceiling effect once the receptor sites are bound. They stay bound. You can take more medicine, but I describe it like having a glass full of water. You put more water in there, you're not going to get any more. Second, because of its these attributes, it stays in the system 24 to 36 hours. So patients aren't doing the normal addictive process. I feel bad, I'm going to take another medicine. They're stabilized throughout the day. Because you have a ceiling effect, you don't get the drug overdose. As far as I know, and I asked people at used to be recommend Keyser last week, has there ever been a death by a Suboxone buprenorphine pure overdose yet? And the answer is no. You take benzodiazepines, you take alcohol, you get it. Now, there's a reason I'm going through this, but I want to set kind of a baseline. I've been treating people with Suboxone for 8 years. It was not something I was interested in getting into. I've had to limit the number of people I get because the demand for this treatment is so high. But in chronic pain, my experience is if you have somebody who has clear physiological pain and the cause is known, and there's no intervention that the physicians are going to make other than putting them on a Tylenol drip or doing these other therapies for which most of the people have failed, and that's why they're in to see me. These people need treatment of pain, or else we're going to have more people like I've had in my practice this year who either kill themselves or make multiple overdoses because their life is so miserable. Right now, this medicine, buprenorphine, naloxone, Suboxone, is FDA indicated for opioid abuse. But let me tell you what an indication means. An indication is how a drug rep can sell or market the medicine. It has nothing to do how a physician can use medicine. I use this medicine all the time for chronic pain. Rarely do people get off of it because if they have impingement syndromes for which they have really severe pain, I think it's foolish to think somehow they're going to stop the medicine, be in chronic pain, and have a quality of life. It's stupid. What we need are two things. Number one is I think we need more abuse deterrent medications. I think that's absolutely important. Again, New England's Journal of Medicine has championed that. And second, and I'm concerned about this policy, I'm going to suggest we need to be using addiction deterrent medication like Suboxone probably for the first treatment after a non-steroidal anti-inflammatory is used. You're going to give a person where the abuse is much less. You have a person that it's much easier to have them, I think, come off the medicine if they have the capacity to do that. And I think we need to be advocating the use of abuse deterrent medications for the treatment of chronic pain. When they reduce tolerance, they reduce addiction. Once the receptor sites are bound with buprenorphine, it's like having a 200-pound guy on a step with a 50-pound kid trying to knock him off. It has a lower K factor, it binds more tightly, and so it's stronger than heroin, stronger than morphine. In other words, if they take those medicines after on this medicine, it has no effect. So I would like to see in our policy at least a suggestion or recommendation or a strong consideration of using medicines that we already have to take these people that we're concerned about, they're already addicted to a medicine, and get them on a medicine that makes it extremely difficult to abuse. Not impossible, but very difficult. And have them on medications that they're not abusing, that can be stabilized on for years, and it also treats their chronic pain so the quality of life is better. Thank you.
Thank you so much for sharing your experience with us.
Bear with me when you talk with an iPad. It doesn't always go smoothly. Is this a good volume? My name is Dr. Kimberly Jackson. I am a disabled family practice physician and an advocate with the Colorado Cross Disability Coalition. I have two areas of the draft policy I would like to comment on. Under Diagnose and Evaluate, Section 2, Assess Risk, the draft policy states if the assessment identifies risk factors, prescribers should first opt for non-opioid treatment options. As the policy has already stated that we should do this with all patients, The statement here might be misunderstood as meaning that we should try non-opioid options first only if there are risk factors. Under Establish an Exit Strategy, this policy states the written treatment plan should highlight how and when opioid therapy will be discontinued, linking discontinuation of the therapy to the achievement of functional goals. Reading this, it seems like providers are supposed to discontinue therapy once pain is controlled and/or the patient is functional. In the case of severe chronic, non-cancer pain, a patient may only achieve their functional goals with the help of non-opioid and opioid therapy. Discontinuation of treatment may result in the return of pain and the subsequent decrease of function. While some patients might be able to discontinue medication after time, others won't. This statement seems to say that all patients need to discontinue opioids after a period of time, and as a result may cause some providers to discontinue opioid treatment, even if it is helping patients reach their functional goal. A better statement might be this plan should discuss the potential of discontinuing opioid therapy, especially if functional goals are not being met. On a personal note, I have multiple autoimmune, genetic, and orthopedic conditions which result in chronic pain. As a result, my pain is severe, multifactorial, and progressive. I have used opioids to help control this pain and to function better in my daily life. Without opioids, I am stuck at home and it is much harder for me to live independently in the community. I also have many friends in the disability community who require opioids to function. Finding providers to treat our pain has been getting more and more difficult, even in a metropolitan area like Denver. This has resulted in many of my friends abruptly losing access to opioids for periods of time, with associated withdrawal symptoms. Policies like this can cause providers to give up on treating pain with opiates, creating access issues to adequate pain management, especially in rural areas. Currently, there is a lack of non-opioid options that can effectively and significantly treat severe chronic pain, and opioids are needed by many patients to control pain. Myself and my friends fear that with all the propaganda about the disease of addiction, that opioids eventually will not be available for people like me who suffer from severe pain due to serious and chronic health conditions. I urge you to keep all this in mind while revising this policy. One of my first patients as a medical student was a young woman who started opioids for a back injury. Her doctor refused to continue to treat her pain, so she bought heroin on the street because it was less expensive than Percocet on the street. My fear is that more chronic pain patients will have to resort to street drugs to medicate their pain as we continue to lose access to pain management. Thank you. Thank you for providing this opportunity to give feedback on the policy.
Thank you so much for coming down and for being a part of this. Got someone here, and then we'll go to the webinar. Amy, right here in the end. Yeah.
Hi, can you hear me? I am quite moved by hearing what has been said so far, and forgive the redundancy in my part. I'm Dr. Jackie Schwartz. I'm a clinical psychologist. I work with a wide range of people from the age of 3 to 88 at the moment. And I have a developmental orientation and a long-standing practice with traumatized children, adolescents, and adults. I did my internship and fellowship at Harvard Medical School. I have taught at CU. I have supervised graduate students as well as professionals through the Mental Health Center of Boulder County. I have done a fair amount of teaching, and currently I'm doing a lot of work with veterans and do pro bono work with asylum seekers who have been both traumatized and damaged physically in the course of their making it to the United States. Inevitably, my work, as I'm saying, has brought me into contact with seniors, adults, adolescents, and children who have struggled with chronic pain, and many more who have disclosed their experiences of acute pain. I very much appreciate this opportunity. I want to assume that the policies are based on good intention, and I am very afraid that taking a singular prescriptive focus, we will unintentionally cause greater harm. Pain is complex, as we've been hearing. The sources of pain are variable, and the skill to titrate medicines appropriately requires physicians, patients, and treatment teams to make their best individualized assessments based on actual individual human needs and based on having the resources to meet those needs. Mistaking a singular policy for a viable alternative solution is deeply problematic in my best professional and personal opinion. The policy, there are a couple of points that I'd like to make. I believe that when you initially began, you mentioned that the policy does not apply to under 18. I fear that my concerns may be a little bit on the opposite side of the one that you were taking. We have a history that is very recent of under-medicating children. It is within my practice that I have heard well-intentioned physicians saying that children just don't experience pain. It is novel for depression to be recognized in children as much as it is for emergency room physicians to be trained in the actual physiology of pain in children. Part of the policy warns against providing opioids to those who have suffered prior abuse. That would unfortunately sound like a justification for withholding pain relief from the more vulnerable. We need highly trained specialists who are able to work with young children especially, and to be able to establish a protocol that is recognizing that kids suffer as well, and that their re-traumatization by not being given ample pain relief can be significant and can have lifelong impact. I have several examples that I can submit in writing if that would be helpful. The policy also does not explicitly clarify what it means when it talks about the elderly geriatric patients in chronic or acute pain. It seems like there's a leap between the availability potentially of medicines for folks who are under hospice care and for that very important senior population and adult population who is in a chronic pain circumstance where opioids and other pain medicines allow them to keep functioning and wanting to continue living, as opposed to choosing to die or feeling their life, the quality of their lives, diminished to such an extent that a range of symptomatology, psychological symptomatology, then emerges that just makes everything more confounded. Apparently, there are handbooks that are specific to what are providing individualized treatment for seniors that have been published by the American and British Geriatric Societies, and I would very strongly advise that we incorporate those guidelines into our policies. A point that again I think was made very, very well earlier, but I will reiterate, is that on page 4 of the guidelines, the policy states that opioid prescriptions for chronic pain require that the patient's functioning will be improved. However, among patients and colleagues, I have encountered those with severe pain that sometimes have underlying medical conditions that cannot be expected to improve. When they are allowed access to appropriate medication dosages, sometimes for multiple years, their conditions may be held at bay from further profound deterioration. I worry that the language in the policy about increased functioning may indicate the need to discontinue or reduce the medication regimen, which is allowing them to maintain functioning. The idea that one can predetermine the dosages at a uniform dose without consideration of the etiology of the pain and the pre-existing corporeal damage seems unfortunately a horribly untoward effect of trying to fix a related but substantially different clinical concern. Thank you for your attention.
Sure. Thank you so much for coming down today. We had one person back here, and then we'll go to the webinar.
Thank you. Can you hear me? My name is Patricia Jackson, and I am the owner and lead clinician for Jackson Counseling and Jackson Consulting. I have been treating opiate addicts, street addicts, and pharmaceutical addicts for 35 years. I have 3 physicians that consult with me regularly. All 3 are reporting the same thing to me, and that is that they are being penalized professionally and economically for not overprescribing opiates. That there is an incentive bonus program in all 3 of their practices, which are unbeknownst to each other. They're 3 separate practices. They meet with me on their own dime because of their own integrity, and they are all reporting the same thing to me. None of them are recovering addicts or active addicts themselves, and none of them are conservative in terms of prescribing opiates. They have no philosophy that prohibits that, but they're describing to me that when there is flagrant evidence of abuse and addiction, if they do not continue to prescribe at the level that that person is accustomed to, the person then writes a scathing review, and those reviews are used to penalize the doctors economically and their status in the practice. I apologize, I have not reviewed the written material, so if this is in there and I don't know where to point out, or if it's not being raised at all, I do apologize for that. But 2 suggestions that I have considered very strongly for a very long time is that there needs to be some kind of central database for docs to be able to track concurrent prescriptions of opiates. Currently, there exists nothing like that. So physicians are really on their own and having to go on their own intuition. And these are good doctors who want to manage their clients' and patients' pain conditions, but are suspicious for reasons that they come to meet with me privately to run by me, and they're very serious things that they're picking up on. The other thing that I would like to see put in place is for physicians to have access to addiction specialists like myself. I've been a CAC3 since 1985, and I've been an addictions counselor in New York State and Colorado, like I said, for 35 years. Physicians have their own area of vast expertise and knowledge, but for those of us who have been treating directly opiate addiction for many, many years, we also have a range of expertise that could be very useful to medical practices. I'm seeing my doctors that consult with me depressed, demoralized, humiliated for doing the right thing. Thank you.
Thank you. Joe?
Okay, is it all right if I read one and then we'll go to one live? Okay. The first is Robin Mauer, I apologize, Robin. The written comment says, I do feel there should be more take-back programs or drop boxes to get rid of meds when no longer needed. Otherwise, people hang on to old prescriptions and use them later, or family members use them. These programs are not widely known and not often enough. Also, there are not many pain management doctors that concentrate on medications. The way they get paid is by procedures, so they oftentimes do not take on patients who are solely on oral pain medications. There are also not enough addiction specialists. Finally, specifically on page 13, it says, providers should exercise caution when prescribing transdermal fentanyl or methadone, but does not give any more information on them or why. There are certain patients who are actually good candidates for these medications. And now we will unmute Jeffrey Williams. Jeffrey, you should be ready. There you go. Jeffrey, are you still on with us? You must be muted on your end, Jeffrey, because you're unmuted on our end. So we'll go ahead and mute Jeffrey again and go to Kristen Muskyard. You are self-muted, Kristen. Okay. Okay, let's go down. Then instead, I will read one more, which says, there needs to be an exception. There needs to be an exception for post-operative pain. I prescribe narcotics for post-operative pain on a daily basis, as I do about 15 cases a week. I used to prescribe a small number, for example 10, because everyone reacts to surgical pain differently. My intention was that this small number would help me wean my patients quickly to a non-narcotic. Using this method, only a minority of folks needed a second script for narcotic. But now, due to regulations or some other factor which I don't know, my patients cannot fill the second script. So now I'm forced to prescribe a greater quantity, 40 for example, in the initial prescription just in case they need more meds. So this is the reverse of what you are trying to achieve. And that was Jeffrey Williams. So maybe.
Okay. Were you able to get in touch with this other self-muted?
Kristen? We'll go to Kristen one more time. There you go, Kristen. We can.
Hello.
Yes. Go ahead.
Can you hear me? Okay.
Yes.
I'm actually a pharmacist who is now retired because I'm disabled, and I am coming from a chronic patient perspective. I was diagnosed with reflex sympathetic dystrophy in 2004 when I broke my right wrist. Since then, I've had 10 more fractures in my body where it's spread through my entire body, and I've had 6 major surgeries. And I guess my concern is, I mean, I follow all the contracts that I have only one pain doctor. That's the only person I go to. I follow the contract. I don't fill early. I do everything that's by the book because being a pharmacist, I know how important that is. And I guess I am scared to death that if something changes, because like for me, my pain is so excruciating. Like I sent some pictures to Holly Weaver of what my legs look like. I mean, it looks like somebody poured gasoline and lit them on fire. And I was averaging 2 to 3 hours of sleep a night. And I guess this isn't the life that I want. And so if I'm not able to somehow have my pain controlled, I don't know what I'm going to do. And I guess I just wanted you to see from a perspective, you know, there are people who don't have cancer but have horrible diseases. There is no cure for RSD. So currently I have no cure, and I have to live with this horrible disease until somebody can find a cure. So that was what I wanted to, I guess, put in as far as my information to you guys.
Thank you so much for sharing your story. And one note I would like to put out there that may help. The policy is talks about what it doesn't include, and it doesn't include acute cancer pain. It doesn't include palliative care. So if you have someone such as the last caller who talks about a disease with no cure, that would fall under palliative care. And it does not include hospice care. So I think in our last policy, we went through and tried to specifically name out diseases that it may not cover. And what we found was that practitioners in the community felt like if the disease wasn't listed, then it wasn't included. So this time we wanted to have a more broadly encompassing term. If that's not clear to you all, then I think then we need to work on the definition a little better to make sure that that's included. Go ahead, let me get you the microphone.
Excuse me, Dr. Louise Silverman, a clinical psychologist. Elise Morgan spoke about the need for research in this, but I have spoken to a number of my clients and to a number of their pain physicians, and in other respects, to a lot of people involved in these issues. I don't think anyone understands the palliative care to deal with any of the issues that we've heard described with a lot of poignancy. And some of the worst intractable pain situations that are not cancer are very idiosyncratic. You're not going to cover it by covering a list of diseases. It is the kind of thing that physicians have traditionally paid a lot of attention to before 2010, when physicians have become very frightened to prescribe too much. They don't have any reason to be frightened to prescribe too little. And yet we know that the effects of long-term uncontrolled pain on the body and psychologically are horrible. And I think we have to take terribly seriously what the CDC data actually shows. They looked up until 2010 at the fact that there were increases in prescriptions and increases in ODs. And they looked in a way at the increases in ODs that are related to opioids. A lot of you know this, but they looked at it in a way that was sure to inflate that number. And I would be glad to explain that. But if you look at their same data collection after 2010, and you look at deaths together with prescriptions, what you see is that as the prescriptions began to fall dramatically, most likely, we imagine, because of the many regulations, there was an increase not only in the number of deaths, ODs, deaths, but also in the rate of increase of the deaths. So it made sense for them, maybe because it's very important, to take seriously the correlation between prescriptions and deaths up until the point of 2010. And think maybe if we can cut the prescriptions, maybe the deaths will drop. We don't really know what's causing it. It was worth trying, maybe. Then we have to look seriously at what's happening now, and I think we've heard a number of reasons it may be happening. That with the increased restrictions on palliative care, if that's what palliative care means, the increase in medical care for the kinds of situations we're hearing about, there's a spike in deaths that doesn't show any tendency to be stopping. There's a spike in heroin deaths at the same time, we've got to try to make sense out of that. Because there's something that's happening that isn't being touched by restricting prescriptions. And I'm really scared for a lot of people whose pain I'm familiar with. But I think if you could clarify that in Colorado, physicians are not going to get in trouble for using their judgment to prescribe for long-term severe intractable pain, for providing palliative care for stable pain when there's physical reason for it, that would make a huge difference to the kind of thing I'm seeing in my practice, the terrible fear and trauma.
Thank you so much. I appreciate that. We have someone over here. And do we have someone over here? Okay, I'll get to you next.
Hi, my name is Stephanie Stewart. I'm a preventive medicine resident at CU, although not representing them. On page, one of the things you mentioned in your introduction was harm management, and I think you have a couple opportunities where you could really clarify that in the policy. So on page 10 about naloxone prescriptions, you mentioned that you would especially consider these for patients with respiratory depression. I think there is an opportunity to specifically mention benzodiazepines, as the combination between opiates and benzodiazepines puts you at a higher risk for overdose. I think also under the PDMP point on page 3, you could add the word regarding the initiation or continuation of opioid therapy. And then I also think there's an point there that can be added that checking a PDMP also allows for an opportunity to prescribe naloxone if you see a concurrent benzo or opiate on their PDMP when you're checking.
Thank you so much. Here you go.
Hi. On.
Go ahead.
Hi, my name is Rachel Rosalind, and I am the director of the Interventional Pain Clinic at the University of Colorado, where we actually do see Medicaid patients, but like the other speakers have alluded to, we lack resources to adequately manage in a true multidisciplinary way the pain of those patients, as well as our patients who are adequately insured. As to the policy, I think it's a very tricky area in which to be exploring as the licensing division, because this is designed to be a blanket statement that applies to a very broad scope of practice. The boards involved in this policy include the nursing, dental, pharmacy, medical, podiatry, etc. So you are talking about a range of providers, from dentists to primary care providers to dermatologists who do skin biopsies to surgeons who manipulate somebody's spine to correct gross abnormalities. I agree that there is a gross problem with overprescription of this class of medications. The vast majority of patients who come into my clinic with chronic pain looking for opioid management are either inappropriate for that class of medication or on doses that I consider inappropriate because of the risk, the lack of functional improvement, or perhaps even functional worsening on those high doses, including the development of hyperalgesia. So I fully support the idea of helping to decrease the initial exposure to opioids, particularly using them at high doses. And I would like to reinforce, and perhaps it needs to be more clearly stated in the policy, that these are bright lines meant to cause pause as an opportunity for intentional and deliberate thought on the part of the prescriber, but they under no circumstance should be used against the prescriber when their clinical reasoning supports deliberate, thoughtful use of these class of medications at particular doses. Same line, these guidelines or these policies should not be used as an excuse by providers to abandon a patient whose class of medication makes their care somewhat inconvenient. Rather, this should serve as an opportunity to avoid the non-beneficial escalation or continuation of opioid medications. I also would like to echo the statement of a speaker at the last Denver stakeholders meeting who asked for greater education of physicians, particularly in primary care, around pain management. And I would posit that perhaps rather than a policy circumscribing dose limitations for providers, DORA and these licensing agencies should really focus on a policy around better education of prescribers and dispensers about appropriate use of these medications for individualized functional pain management goals. I do appreciate the focus on function, and I will say as a personal aside that I think in general, some of the opioid problem in our country reflects a problem I see every day, which is patients who walk into my clinic asking me to fix them. And unfortunately, for chronic pain, like most chronic conditions, there is nothing I alone can do to fix the patient's problem without their engagement and active participation in that process. And in our current situation, as the other speaker alluded to earlier, we lack the resources for patients to do so, to have access to these non-pharmacologic modalities to help manage pain. Thank you.
Thank you.
Oh, and I'm sorry, and I would like DORA to use their position to advocate for those resources.
Okay. Thank you. We have someone over here, and then what?
Go ahead.
Okay.
Then we are going to unmute Jeffrey Williams. Hold on one sec, Jeffrey, and we'll see if we can make this work. Jeffrey, we can.
Hello, can you hear me?
We can hear you. Go ahead.
Yes, I'm a surgeon, so I just kind of I basically do about 15 cases a week, and the problem that I see in policies such as this is trying to manage the post-operative patient. I prescribe narcotics essentially almost on a daily basis just for post-operative care. I used to prescribe approximately 10 pills for severe or for a big surgery, in the hopes of trying to wean my patients off very quickly after that course, because everyone responds to pain in different ways. Now what's happened with, I do get kickback from the pharmacy quite often now over the past month or so. I don't know what's changed in the form of regulation or insurance requirements, but the fact of the matter is I find myself having the inability to prescribe some of those patients, that minority of patients that are unable to just make it by with the one script of, say, 10 or 15 pills and may need a second prescription, but I can't get it for them because their insurance won't allow it. So I think regulations like this need to take into account the post-operative pain control for situations such as myself, and have those folks in mind when you're trying to treat post-operative pain. That's my only comment.
Thank you, Jeff. Oh, sorry.
Okay. Over here.
I apologize for being late.
Let's,
So, I apologize for being late. So this may have been addressed, but I doubt it. My name is Mike Plotnick. I'm a OBGYN in practice here for 13 years. New York City before that. Ivy League background, chief resident Sinai. I've got 10,000 deliveries under my belt with a 0 body count. And what's not being addressed here is the pregnancy issue. I see on page 2 that there's a blank space, and I think that was put there for me. So
it was.
So I'll explain. In 13 years here, I've never seen a single pregnant woman detoxed during pregnancy. On a national level, in some tertiary care centers, half of the beds are filled with babies that are withdrawing. And we're doing that. This room is doing that. Well-intentioned, and that's the hardest part for a New Yorker to understand, is that people are actually well-intentioned. But that has to stop. It has to stop for a number of reasons. One is the medicine is not there. I just took the buprenorphine prescribing course up in Seattle, went up to mostly see the eclipse. But the data that they spoke about with pregnancy was, I believe, 1969 and 1972. Which said higher rates of miscarriage, stillbirth, preterm labor, all that kind of stuff. So we don't usually quote 40 and 50-year-old studies to our family practice residents where I teach. The medicine that you guys are basing your pregnancy management on is profoundly outdated and completely wrong. The Gray Journal, which is one of our maternal fetal medicine journals, clearly has shown over the last decade that women do not have higher rates of preterm labor, miscarriage, and abortion when you detox them. Now, within this course, they talked about, and I raised my hand and said, hey, what about willpower? Oh, it's not a willpower issue, it's addiction. But within the course, they talked about 2 special groups, motivated people, and they were actually airplane pilots and physicians themselves, and they got off the drugs at about an 85% level. So within the course where we talked about how motivation doesn't matter, motivation matters. Pregnant women are a motivated population, a highly motivated population. And in 13 years of being here, I've never seen a single pregnant woman who wanted to be detoxed. I've seen their doses go up and up and up and up. Now, the downstream of this is you're filling the neonatal units with addicted babies. And we call it neonatal abstinence syndrome, which is a wildly inappropriate term because babies can't abstain from anything. Adults can abstain. If you want to put a politically correct face on it, call it NAS. But it's not NAS. These babies are not abstaining by the definition of abstaining. They're withdrawing. Okay, it's a week. You know what? It's not. It's a month. You know what? It's not. It's 2 months. And you know what it's also? It fills the NICUs to the point where NICUs get to close because they're going broke. And that affects the rest of the community, if you want to talk about community resources. You know what? Forget the vomiting and the nausea and the jitteriness for 2 months. Forget all that, because that'll pass. But what doesn't pass is the permanent neurobehavioral injury that occurs to these children. Caveat non nocere, first do no harm. So our prescriptions to these pregnant women are not only causing immediate harm, filling NICUs, costing tons of money, making babies sick, but they're also damaging them forever. You've got non-graduation from high school, early pregnancy, car accidents, suicides. You want to talk about mental damage. This is mental damage that we are causing through our prescriptions. You're not getting this stuff on the street. We're writing these prescriptions. So you've got ancient data, which doesn't apply. You've got injuring babies, which no one wants to talk about. You've got losing your NICUs, which is happening in this state, and damage to the communities. So this plan here is a wonderful plan, I see. And I'm not addressing chronic pain in other venues. My venue is obstetrics and gynecology. What we've been doing has been a miserable failure. And what I'm calling for is that these drugs, including methadone, should not be prescribed by anyone other than either a family practitioner who does OB or an OB doctor, because only we know what happens to these pregnant women and to their children downstream. And I'm sorry to have to say that, but I think that pain management doctors have completely failed our pregnant women. The literature that you guys are following is a generation old, and you guys should have been reading up on your journals a little bit more than that. So I apologize. I know you don't want to hear this, but harm is being caused every day to innocents by the people in this room. Thank you.
Thank you. Okay. So we have a person over here in the back, and then we'll come over to you.
Hello, Patricia Jackson again. I just wanted to follow up on what this physician talked about. I was a counselor for 3 years at Whitney M. Young Health Center in Albany, New York, which is the methadone program, and then I also was a lead counselor at the University of Colorado Health Sciences Center, Addiction Research and Treatment Services, which is a methadone program here in Denver. We regularly detoxed pregnant women with great success. They were followed through the breastfeeding process. There was close contact with the treating OBGYN. So there may be a disconnect between private practitioner OBGYNs and the resources at a methadone program. But we did that with great success. We were always detoxing, I would say, at least 3 or 4 pregnant women at any given time, and completely getting off the opiates as early in the pregnancy as possible throughout the breastfeeding process, and if there was an underlying pain condition, then reintroducing them at a much lower dosage.
Thank you.
Just getting back to, you had asked a question a while ago about kind of the definition of palliative care, and I do think that that's something that perhaps you guys should just think about. I think from most physicians' perspectives, when we hear the term, an exception for hospice or palliative care, those are either people who are enrolled in hospice, obviously, or for palliative care, cares that it is being directed by a board-certified, fellowship-trained palliative care physician. And I think that we have to be careful about if we're just going to change the verbiage to any care that is palliative versus true capital P, capital C palliative care. All opiates are used to palliate pain. So if we want, I just think that definition matters and is important. But I think when you guys are asking kind of what does that mean, I think for most of us in the community, when we see the word capital P, capital C, palliative care, that to us means care given by a fellowship board certified palliative care physician.
Okay, thank you. Do we have anyone online?
Mm-hmm. I have a comment. This is Robin Mower again. I worry that insurance companies will take this as law and it will make it more difficult for patients who really do need to get opioids. Insurance companies will take 50 milligrams of morphine as a set number and not allow doses greater than this to be insured. I have a doctorate in pharmacy with a residency in hematology oncology. And furthermore, when we talk to people at the insurance companies to get prior authorizations, we are talking with people who really have no education of these drugs, are not in healthcare, and are simply not authorizing based on an algorithm. They don't understand the clinical picture. It takes hours on the phone with insurance companies to explain why an opioid is prescribed, often requiring a peer conversation. Rather than physicians concentrating on taking care of patients, they are on the phone with people from insurance companies explaining why they are prescribing opioids. Also, 90 days for a chronic pain patient is not really chronic.
Thank you. Anybody else? Don't be shy. There we go.
I guess just one more voice from the profession of pharmacy is, when you read the Controlled Substance Act, there's a corresponding liability for every prescription that's filled. And I know certain states, for example, Florida, has now taken a legitimate prescription to encompass that idea from the law, meaning that not only does this meet the physical factors printed on the prescription and the prescription paper, but it now has to make sense in a medical perspective, that the use is in fact appropriate, those kind of parameters. So I'm not sure if this state is heading in that direction, putting that responsibility on us. If so, what does the state expect pharmacists to play? What role do they expect us to play in living up to our liability of the prescription and its medical necessity? I think we could use some pretty clear direction because there's not a whole lot in there for us.
Thank you. Anybody else?
I have another one.
Okay.
We will unmute Lisa. Let's see. We'll unmute Lisa Volk. Go ahead, Lisa.
Thank you. I'm going to try to work backwards if I can from everything I've been listening to. The gentleman that just came in, very passionate, OBGYN, that only they should be able to prescribe is a little bit overkill, since not everybody is a pregnant female or can become one. That's kind of crazy. I mean, there's men, there's people who are over the age, under the age. It's nuts. It doesn't make any sense to say that everybody in this room is causing the problem. I do believe that there is a difference between dependence and addiction. There's two different things going on there, and people confuse them. And there was a woman before who said, we got to get to what's really going on. Well, the underlying causes of addiction are not, oops, I took a pill and now I'm addicted, for everybody. It's despair and hopelessness. You can't just say, oh, look at the deaths and now look at what's happening to the prescriptions. People do this for various reasons. There are addicted people who can get addicted and people who don't. A lot of studies show that people who have chronic pain don't have the addiction issues for various reasons. If you have to use it for pain, you get to a point where it controls your pain, and that's it. You don't keep escalating and escalating and escalating for the most part. You get there, it controls your pain, and you stay there, because as a chronic pain patient, you know you need that stuff, and you cannot keep doing that or you will run out of ceiling. There won't be any room. So the other person who was talking was the earlier man who said, the psychiatrist who said there's no trouble getting treatment. That's absolutely his perspective is from a medication perspective. Yeah, you can get treatment medication. No, you can't get treatment. Inpatient addictions treatment is what I'm talking about. Inpatient addiction treatment for people who don't have money. It's almost impossible to find it. Believe me, I tried to find it for tons of my patients. Not findable. So, and also the woman who said she wants to be able to track concurrent prescriptions, her 3 physicians who are getting punished for under-prescribing, which is really unusual. I'd love to know more about that. But the pharmacists have that system. It's a statewide system. That's why that other woman got caught and flagged, because they know, oh, this prescription over here and that prescription over there. So there is a system. Whether doctors could get into that system, I don't know, but there is a system that exists right now for flagging concurrent prescriptions. That already happens. So hanging on to old meds, I have a ton of old meds. I could not give them back anywhere I tried to give them back. And now I'm starting just now to see, you know, oh, you can give them back on this date at this place. So that person was correct. There should be more opportunities to do that, more advertised opportunities. And I really want to thank the woman that is treating the people, the Medicaid people at the hospital, who said the focus should be more on educating when we need to use this, educating more broadly, and advocating for the resources that are non-opioid, the therapy, the physical therapy, the stress reduction. All that stuff is super expensive and nobody covers it. You know what? Opioids are super cheap. So where's the fault? Where's the focus? In this country, we have a drug war that doesn't work. So people go out and get their drugs, they can still get them. So it's never going to be solved if we don't solve the underlying, address the underlying problems. So yes, you can get treatment by drug, but you can't get treatment for the underlying despair, hopelessness, inpatient treatment if you don't have insurance and money. That's the deal. So anyway, that's basically all I wanted to say as I'm listening to everybody and everybody's passionate. Everybody's right in their own way. They have their own experience about what's going on for them. And that's the truth. Unfortunately, a lot of times policymaking doesn't do what you guys are doing. So I appreciate very much that you are taking all these comments from all over the state. Very, very much.
Thank you so much. We appreciate your input and your feedback as we move forward with the policy. Do you have anyone else online?
No, just someone was clarifying that the PD, you might want to just,
right,
that doctors.
Right. So I think one area that we can clarify is that we do have the prescription drug monitoring program in Colorado. That program is run by the Colorado Pharmacy Board. That program monitors every controlled substance that is written in the state. And pharmacists are responsible for putting those in when they dispense the prescription. So I guess I'll backtrack a little bit. Every prescription that is dispensed is recorded in the prescription drug monitoring program. Every prescriber in Colorado is required by law to have a registration to that system. And that's the sticky wicket, is that the law requires that you register and have an account, but the law does not require that prescribers use it. And that is why in the policy we encourage prescribers to use that tool. It's a valuable tool. There certainly are downsides, as one of our stakeholders expressed, that you can get flagged or a push notice would go out to your physician. But as prescribers, it's a very useful tool to ensure that the patient that you are treating is treating with you and not treating with multiple providers. It helps particularly with medication interactions. If you have a patient who has a psychiatrist who's treating the anxiety with a benzodiazepine and you don't know about that, and you're prescribing opioids, that puts the patient at risk. So it is a very useful tool. And so we want to clarify that for everyone. Go ahead.
Hi again. As I'm listening, I'm finding myself agreeing with people I didn't think I would agree with, and I'm wondering what's going on with me. And I realize that, if you'll permit me, I think there's an underlying major conceptual mistake that we are all kind of trying to find our way out of. And that is the conflation of addiction with pain. They are both clinical entities. They are both independent clinical entities. While it is the case that the treatment for pain can sometimes potentiate the underlying vulnerability for addiction, which we now accept to be a disease rather than a crime, that is an iatrogenic effect, which we have in other areas as well, and we deal with. It's an unfortunate iatrogenic effect, but like with other iatrogenic effects, we need to treat it. And there are places who treat this iatrogenic effect. Addiction has a separate kind of treatment. It is not the same treatment as pain, and pain does not need the same kind of treatment as addiction. The fact that there is comorbidity doesn't mean that you go after the treatment for one as the cause for the other. I guess I don't know whether this is possible, but if it is possible, can we reconsider the basic premises of this? Will we get addiction specialists who see the damage being done by overprescription, and the pain specialists and the OBGYNs who see the medical piece of this, either the need for withdrawal treatments or the need for more comprehensive pain treatments? Can we get them together to start a more rational policy? You've provided this incredible forum for us. Can we use it to go ahead rather than just rearrange the deck chairs on the Titanic?
Thank you.
I wanted to get clarification about the pharmaceutical database. So any prescribing physician can go in and get the entire history of their patient's prescription use?
Yes.
Because I just got a call yesterday from a surgeon in Chicago who, a client I had worked with years ago, had an adverse reaction. The family did not disclose his addiction history. So the physicians apparently do not know about this or how to access it, because in current time, not historically, I'm interfacing with physicians who are scrambling to find out all the medications their patients are on.
Okay.
So I don't know.
Well, so first of all, it's not all the medications. It's controlled substances.
Just controlled substances.
Right, and it's for Colorado providers. Now, there are links with other states, but I can't speak as to what Chicago physicians would have.
There isn't
available.
a national database of it. Okay.
No.
Okay.
Okay.
Thanks.
Do we have anyone else? Sir?
My name is Aaron Lynn. I'm a general surgeon. I just recently completed my training, but I'm practicing in Colorado. The one thing I'd like to say about the policy that concerns me a little bit is the number, that line in the sand that you're drawing at 50 milligrams morphine equivalent. I think that number needs to be changed. And in my training, we would regularly, and even with reductions in the amount of opiates that we were trying to learn to prescribe to patients and seeing beneficial effects to having fewer opiates out there, we would still be violating this number of morphine equivalents daily on a regular basis with our general surgery post-operative patients. I think that when you create a policy, even though it's not a rule, it does set the ground, it sets a line in the sand that you can start blaming providers that are violating this policy. You can say you regularly prescribe more than 50 milligrams of morphine equivalent daily to your patients when they're post-operative. And because you're doing this on a regular basis, you're in even though it's not a rule, a violation of the policy. And I think that scares physicians, and it causes physicians to undertreat patients. And I think that's a big problem when you start to create a one-size-fits-all policy that is, like another one of our colleagues had talked about, is designed to encompass everything from physicians to nursing to podiatry to dental work. I think that it's just too broad of a policy for prescription of narcotics or for opioids. And I have concerns about just the number that you're saying in that. I think that we probably should have that be increased. One of the guidelines that I would use, or one of the things that I would say, is that 50 milligrams morphine equivalent daily is on the order of 25 milligrams of Percocet daily, which is about 5 Percocet pills. And most of the physicians that I see prescribing for post-operative pain would prescribe in excess of 5 a day. I think that number is too low to start with. And I don't think that we should be trying to say that all patients are treated in the same way when something like pain is a very difficult thing to determine, even in opioid naive people, how much pain medication they may be requiring. I hate the idea of sending somebody home with 5 pills a day of Percocet and having them be in pain, or having them have to go to an emergency room in the middle of the night to be able to get a prescription refill because we're too scared as physicians of the repercussions of a policy like this to prescribe our patients adequate treatment.
Thank you. Anybody else? Got someone here?
Please be sure to state your name.
People on the webinar.
Hi, my name is Dr. Sharmish. I'm a pain specialist. I'm board certified in internal medicine, physical medicine rehabilitation, subspecialty in pain management, also eligible in electrodiagnostic medicine. I'm not sure where to start. I agree with everything that everybody has said. I've been doing this for over 20 years here in the state of Colorado. I have a whole collection of non-malignant pain patients who have been on high doses of opioids for many, many, many years. They're very functional, lawyers, doctors, so on and so forth. And then for them, it's their only alternative. When I was trained in internal medicine as well as physical medicine rehabilitation, we were always taught to treat the patient, not the numbers. So this arbitrary number of 50 morphine equivalents, I'm not sure where it came from. I know it's from the CDC guidelines, but I don't agree with it. I belong to the Colorado Pain Society. We don't agree with it either. We're a collection of pain management specialists. We still think it should stay at least 120 morphine equivalents. Quite frankly, I don't even think there should be a limit. You should treat the patient, not the number. Chronic pain is like any other disease. Probably the most common thing that all doctors see is pain. If you have a patient comes into your office that has high blood pressure, if their blood pressure is 220 over 120 and they're on 10 milligrams of Norvasc, you're not going to say, well, we can only give you 10 milligrams of Norvasc. You're going to treat the disease state with whatever you need to treat that disease state. If you have a patient comes in with diabetes, for example, their blood sugars are at 400, you're not going to say, well, you can only have 10 units of regular insulin, NPH. I treat patients that have debilitating diseases like multiple sclerosis, spinal cord injuries, central pain syndrome, a lot of non-malignant conditions that require high doses of opioids. And I'm running into increasing difficulties to try to get medications for these patients. I go through all the guidelines, recommendations for safety using the PDNP, the urine drug tests, sign the contracts. I do a thorough history and physical examination. And yes, there are some patients that do slip through the cracks, but I think I've done a very good job of trying to eliminate the ones that shouldn't be getting these medications and keeping the ones that do. But the ones that I keep that do have legitimate chronic pain and take the medications as they're taken, their disease state is under good control, are now having increasing difficulties as a consequence of your actions. Furthermore, if you look at the statistics, over the last 2 years, the deaths from prescription opioids have gone down for the last 2 years, which is the first time ever since they've been keeping track of these things. Concomitantly, like some of the other speakers have said, there's been a huge surge of heroin in the streets. And that's where I think the problem is. I think we're all barking up the wrong tree here. We need to get the heroin off the streets. I'm not a big trumpeter, but he's right. It's coming across the borders. I had a patient of mine, lovely lady, worked full-time, horrible spine. She had rods up and down her spine. She was on high doses of opiates. I was able to get down to a nice, legitimate level of opioids. She came home and she found her son dead on the floor, okay? And I was afraid that he might have gotten into her opioids that I prescribed for her, but she had them all locked up. She went on her iPhone and found that she was getting fentanyl from China, which is so easy to get now. That's where the problem is. It's on the streets. It's not in the doctor's office. It's not the prescribers. Yes, there are some problems with that, but the huge surge of deaths from opioids is occurring on the streets. So I think we're making this problem worse by what we're doing here, not better. The more people are dying, not only just the people getting heroin on the streets, but also the people that are getting their pain undertreated. There's going to be an increase in depression causing suicide. There's a lot of studies in the 90s, the decade of pain, that showed that untreated pain causes changes in the brain, increased depression, increased suicide. So I think we're causing more harm than good by what we're doing here. And I think we need to let doctors be doctors, do what we do our clinical assessments, and make the right decisions on our patients. I think you guys have done a pretty good job of shutting down these, quote, pill mills. I don't see those that much anymore. But we do have patients that are not getting their pain legitimately treated. And I think this is a problem. Arbitrarily putting a number at 50 morphine equivalents, I think, is irresponsible. I think you need to base it on patients' clinical judgment or doctors' clinical judgment and the way the patients present. As long as these patients are taking these medications legitimately, not diverting them or misusing them, I think they should be allowed to have whatever pain medications they need to get their pain controlled. Now, you said palliative care. That's kind of a broad term. I see a lot of patients that have osteoarthritis. That's not a curable disease. It's quite debilitating. A lot of the patients that have osteoarthritis are in the Medicare population. They have a lot of comorbidities, such as chronic kidney disease, ulcers in their stomach. They're on a multitude of other medications that cross-react with the non-opioid medications, such as they're not candidates for the non-opioids, which is another problem. We don't have any alternatives to opioids. Where's the research? Where are the other alternatives? We do have other medications that actually have been shown to be safer, but the insurance companies don't want to pay for it. We have abuse deterrent formulation technology medications that would help reduce the amount of misuse, disuse, and diversion of medications on the streets. 2 years ago, I presented in front of the House to try to pass the House Senate bill that would make it mandatory that if doctors wrote dispense as written for an abuse deterrent formulation technology drug, that would hopefully help reduce the misuse and diversion of these medications. Then the insurance companies would have to fill it. But the insurance commission was there at the same meeting, and they won out. So I think we're having issues. I think we need to get the insurance companies on board and try to help create more more programs for patients that have addiction. The hospital I work with, we used to have an inpatient treatment unit for alcohol, drugs, and so on and so forth. That got shut down because there's no funding. There's no money in it. So I concur with all the healthcare, psychologists and addiction treatment specialists. We need more funding to help these people that need it, that truly have addiction. The other issue, there's no public education. Last year, for a brief period of time, there was a commercial on TV that said, talked about, dispose of your opioids appropriately, don't share them, on and on. We need to educate the public. That's where the problem is, because the graph and the statistics show that the opioid deaths are from the heroin. And that's the other problem. We shouldn't lump prescription opioids with heroin. Heroin should be a separate, that's a social issue, not a medical issue. I don't prescribe heroin, okay? But heroin's cheap. It's readily abundant. It was in my son's high school, Golden High School. There was a heroin epidemic. And heroin's been around a lot longer than a lot of the opioids that we prescribe. I mean, Janis Joplin, Jimi Hendrix, so on and so forth. They all died of heroin overdose. There was no OxyContin at that time. So we are making strides, I think, by doing what we're doing here. And I think, as you can see, the last 2 years, the deaths from prescription opioids have gone down. The first time in years that they've been keeping track of it. And at the same time, the heroin overdoses are skyrocketing. And that's where the problem is. That's where we should be looking at, not here.
Thank you. Do we have anybody else? Go ahead. Do you have someone?
Yeah, I do. This is rather lengthy, but I want to read it. It is from David Columbus at UC Health North Pain Medicine. I've been practicing pain medicine for 30 years now. I've seen the pendulum swing to, in my early years, with very little opiates written for chronic benign pain, to the 90s and the explosion of opiate prescribing, massive pharmaceutical marketing to prescribe opioids in massive doses, and the policy that they are not addicting, to now that opiates are bad. The opiate overdose problem is real. I see insane prescribing every day in my practice, and now I see entire practices completely stopping opiate prescribing and dumping these patients on the pain practices who are not equipped to handle these large numbers of patients. What I see What I see is prescribing to patients with past history of substance abuse, strong family history of substance abuse, patients who overdosed on opiates given the same medications back upon discharge, patients with significant mental health issues given opioids, combined with benzodiazepines and other depressed drugs. My issues is we have an entire generation of patients who have been given massive doses of opiates for decades, and now we are faced with the new guidelines. How are we going to manage these patients? I can tell you with 30 years of experience, we are not going to manage them. We are not going to wean these patients off of their medications, whether they are appropriate or not. There's very little evidence that opiates are chronic benign pain, but much evidence that long-term opioids are actually helping the pain, making the pain worse with hormone imbalances, depression, immune suppression, and opioid-induced hyperalgesia. One of the biggest issues faced daily in my practice is the lack of access to quality psychological care for these patients. We all know that the literature has shown that multidisciplinary treatment is the most effective way to manage chronic pain, but there is little, if any, access to this type of care. Thank you very much.
Thank you. So I want to make sure that we talk about next steps. We have another stakeholder meeting set for November the 14th. We're hoping to get even more people involved, get their perspective. We will take all your comments, and we will, and when I say we, myself, the program directors that I'm going to introduce in a second, and the prescribing boards. Each prescribing board has a member that's on the work group, and we work through your comments and see what revisions we need to make to the policy. Once that's completed, then we will have another stakeholder meeting to look at that change. And our goal really is to get this policy to the boards, some form of this policy, within hopefully in the first quarter of 2018. So we've got a little bit of time. And I wanted to make sure that you all know that we can't do this without you. We appreciate your input. You are out in the community. You know how it works. You know how the written word is perceived. And that is incredibly helpful to us. I want to introduce Amy Storm. She's one of our microphone people. She is, oh, I'm so sorry. She got married, Amy Belay. And she is a member of our SWAT team. So she moves from board to board, and she served briefly as the interim program director for the dental board. Darcy Magnuson is our program director for the mental health boards, and she's been very active in helping us incorporate a mental health component. We have Paula Martinez. She is the program director for the medical board, and she's been quite helpful. And we have several staff members of Vanya Montgomery and Holly Weaver who helped set up and get everybody signed in. We have Abby Gaskins. She's the interim program director for the veterinary board and the, don't tell me, podiatry board, who are involved in this. And earlier we had Zen Mayhew, who was here to represent the optometry board. And Director Hines was here for most of the meeting. Any of us are available if you have questions, concerns, bring them to us. We are all very dedicated to putting out the best policy that we can, and making sure that within our reach, we can contribute to combating this problem. And I'd like to say within our reach, because I think what's important to realize is we don't regulate insurance companies, and we can't tell insurance companies what to approve and what not to approve. We don't regulate facilities, so we can't tell facilities how to act, but our boards do regulate the practitioners, and that's the piece that we're trying to work on. I think if you look at the preamble, we talked about combating this crisis and treating pain. It's multifaceted, it's multifocal. You have to target it from many different areas. And so we're hoping through this policy to help with our area. That being said, I'm always interested to hear what the barriers are in the community, because I think that helps us think creatively when we put out a policy such as this. So thank you so much for coming. please feel free to come again on the 14th if you're interested, or just make sure to keep checking back with the websites for next steps. And we'll definitely send out a notice, but it's always good to check the website because we update that first.
Karen, there was one question from the webinar about how to contact us. So that information is on the website. You can send written comments to the address on the website. And there was also a question about, is there a pharmacist involved on the team?
There absolutely is. We have a member of the pharmacy board, and we also have the program director for the pharmacy board who is out of the office today, Wendy Anderson.
Okay. Check the website. Thank you.